Thanks, Kevin. So these are two of my favorite people in the world, Carmen and Katie. They're my academic daughters. This is them receiving their MD, PhD, and PT, PhD at age 30. Well, they entered our prospective studies at age 16, tore their ACLs, and Carmen tore her graft. And as you see, they have their cartilage resurfacing procedures 14 years later. The problem is Carmen and Katie are more the rule than they are the exception. So what we do is we use this approach called preventive biomechanics, and we look at musculoskeletal issues, and I'm going to talk about ACL and cartilage. But we also use this approach for things like obesity, activity, concussion. We're getting in more back into cardiomyopathies, and then what we do is we get the entire medical team, and Mayo makes this easy. Actually, the research is really purely integrated into the clinical program, and working with guys like Aaron Critch and Mike Stewart makes it super easy for us scientists. So injury mechanics, it's common injury. Females are predisposed. The good news is about 70 to 80% are non-contact, which means they're preventable. It's something internal to the body, the way the musculature is activating and recruited, and we can prevent these injuries. I'm going to talk about how. And basically, it occurs very early, within somewhere between 33 and 67 milliseconds of foot touchdown, and it's multiplanar applied torques and mechanics overall. This is Michael Owen tearing his graft back in 2006. What you see is a very common mechanism of the trunk going laterally, carrying the ground reaction force with it, pushing the hip and the knee in, and collapsing his ACL. So when we see these injuries, what you watch as many of these videos as you can watch carefully, you see this very common mechanism, the body in this lower extremity valgus position with the knee and hip caving in, low knee flexion at the start, single leg, most of the weight on a flat rotated foot with the center of mass away from the body base, again with that ground reaction force tracking lateral to the hip and the knee and collapsing them inward. When you look at the knee itself, what you see is this combination, if this is my fibula, of knee abduction, which really is distal tibial abduction, anterior translation, especially of the lateral compartment, internal rotation occurring together relative to the femur, and rapid acceleration of the joint and failure. So can this be prevented? Yes, absolutely. So Kate Webster and I did a meta-analysis of all the meta-analyses in the literature, and basically this reiterates what we showed back in the first study in 1999, which was that you could reduce 50% of all ACL injuries in all individuals, and you can reduce by 2/3 ACL injuries non-contact in females. And this has garnered a lot of attention. This now has an altmetric score of about 650. And recently, with Lynn's group at Delaware, what we did is we put together an exercise-based clinical practice guideline for physical therapists. And this has garnered a huge amount of attention in a very little time. So this is a very hot topic. The reality is, absolutely, we can prevent these injuries. It's not even, this is unequivocal. We can prevent these injuries by half in all ACL injuries, 2/3, and this is a great resource for people to go. It has videos, it has programs. This has been a great thing because people always ask me which program, and I hate to say, well, use mine, use this, because it's really comprehensive. So what we've done for the last 25 years or so, as George Davies keeps pointing out to me that I've been doing this too long, but what we do is we use the consilience of different research approaches. So we do in vivo data, full body 3D mechanics on individuals. We feed that into cadaveric models. We feed that data over into in silico models, and then we validate and optimize, and where we throw all those data points together, where they intersect is we know those to be the true and valid answers to mechanistic questions. So ACL injury mechanism is a combination of external loads involved. Basically, you have knee abduction, anterior tibial shear, and internal rotation. And believe it or not, even to this day, this is actually questioned because a lot of people say, no, it's just straight anterior shear due to a massive quad contraction. Well, that's wrong. Sports injuries all happen in 3 dimensions. So how do we know this? Well, we started out in the 80s. This was work we did with Ed Grude and Dave Butler, and basically we just pulled ligaments apart and showed it took about 1,800 newtons of load. And in New York, Torzilli's group did the same studies and showed it was 2,200 newtons. Even cadavers are tougher in New York than they are in the Midwest. And basically what we followed that up with is we did a lot of robotic studies. And this was one of my students' thesis projects. And the problem with the robot is that it's too slow. And so what we did is we started looking at this, but on the robotic data, what you clearly see is males and females have similar mechanisms, though slightly different. The loads are higher and the strains are higher in females more quickly. And basically what they lead to is when you have this combination, it leads to high strain and then rupture. So then we decided, well, let's look at this in a faster concept. So we started using impact simulators that we started develop back in the early 2000s. And this is what our current impact simulator, this is version 3.0. The first one was out of Cincinnati, then Ohio State. This is our Mayo version. And basically what we can do, and this is Aaron Critch doing a scope of the knee. So what he does is does a knee exam prior to the simulation, and then it looks just like he sees in surgery. So we can do amazing things actually with this highly valid clinical model. So rupture outcomes are highly clinical relevant. Again, femoral avulsions, complete mid-substance tears, partial mid-substance tears. And if you look at the injury patterns we get relative to what's reported in the literature, it's exactly the same. And so when we look at things like sex differences, what we see is normalized to cross-sectional area. Female ACLs have more peak strain. The strains go up faster. No differences with the MCL by sex. And sex differences in forces, the flexion moment is significantly greater in males. Abduction moment is significantly greater in females. And reduced knee flexion correlates to out-of-plane generation of moments at landing. And this goes back now almost 15 years. We showed in prospective studies, those studies that Carmen and Katie were involved in, that those individuals that went on to a subsequent injury had about 8 degrees more abduction, about 10 degrees less flexion. So again, multiplanar moments and angles. And then when we add in something like Carmen and Katie actually both have Ehlers-Danlos syndrome, so they're Gumbies. Basically, they can go into a lot of recurvatum. And basically the way I think about it is this: if you have like nice tight passive restraints and good dynamic control, you have low risk. If you're compromised in one or the other, you have moderate risk. But if you have that combination of high dynamic loads, low dynamic control, and weak passive restraints with a lot of range of motion, you're going to get a lot of loading. And basically what we showed is when you put in, along with the abduction moment and that laxity, about a 9 times higher odd ratio of tearing your ACL. So the ACL is it's a highly elastomeric tissue, but it's more than just that. Kennedy, Schultz, Johansson shows it's about 3 to 6% mechanoreceptors. It has every type of mechanoreceptor, including free nerve endings. And after the ACL is ruptured, that sensor is gone. Does the sensor return? Probably not. What you're doing as rehab professionals is developing. So basically, I think with this analogy, you've blown a fuse, you've got an open circuit. So what happens is you've got from the afferents to the spine, you've got this on signal. And then you have inhibitory spinal neurons that turn the efferents off. So even though you've got an open loop and you've got an on signal, everything is turned down, and that's why you start getting atrophy. And what you guys are doing is you're developing parallel circuits, other circuits, through skin, through vision, other pathways. So the ACL is it does resist, if done properly, it does resist anterior translation. It does not resist internal rotation very well, so it doesn't, in all 3 dimensions, control the same way as before, but it most definitely does not provide sensory input. This is a series of studies we did with a couple experimental psychologists, Kevin Shockley and Mike Riley at Cincinnati. And basically what we're doing is she's had her ACL reconstructed on that side and she's swaying at 0.6 hertz. She's got a biofeedback screen in front of her and she's moving toward and away from that rectangle, trying to keep equidistance to it. This is a young population. This was at a Cincinnati Children's Hospital, average age 16 and a half years. And basically, we had them bring a teammate in. So what we had is somebody that was playing the same position, a friend of theirs, same basic height, weight. We could control for a lot of biomechanical factors, same sex, even same position. And basically, this is what the normal kids that had never been injured look like. When you go from 0.2 to that higher sway where she was, basically the joints go from in phase with one another to 180 degrees out of phase, and then you also have a lot more complexity, a lot more noise in the movement. Whereas this is what an ACL injured subject looks like. Basically have low sway, there's more variability of motion, and then when you go to a high speed, they lock down in degrees of freedom. That's that stiffening strategy that you see in ACLRs. This is what it looks like someone that goes on to a second ACL tear, exactly the opposite pattern. At the low velocity sway, they're out of control. They don't sense the joint well. They have a lot of variability. They're 180 degrees out of phase. And then when you go faster, again, they stiffen up the joint and lock it down. And this is what you see very often in the rehab setting. This is a nonlinear dynamical systems approach called cross-recurrence analysis, where if you look at that first panel on the left, as you see, the phasing of the lower extremity joints is very linear, very continuous. Someone who's had an ACL reconstruction, they don't sense the joint as well. They've lost that sensor, and that continuity and linearity start to break down. And then on the far right, what you see is someone who's going to subsequently go on to an ACL tear, doesn't sense that joint well at all, and that continuity and linearity are completely broken down. So the question is, can we prevent second injuries in these individuals? And this is where a lot of our work has gone. And we're basically following Lynn up on a lot of what she's doing. We're learning from her, and we're just trying to extend this work. And basically, if you look at movement biomechanics, high risk versus low risk, this is kind of our working theory here with ACL sensory loss. So down on the far right, what we see is in this video, what we see is these movement biomechanics and altered movement and neuromotor control, but we don't think that's the cause. We think that's the symptom. What you have is this ACL sensory loss, you get this arthrogenic muscle inhibition, then you end up stiffening the joint, loading the joint in a different way, and you end up with chronic swelling, inflammation, muscle atrophy, structural changes in the joint, and then what you see down in the line are these dysfunctional joints and movements. Bone bruises are a problem. So again, as you see, this is the pattern. You see it's usually in the lateral compartment from that valgus mechanism. Again, the tibias come anterior, so basically on the lateral compartment, the posterior tibial plateau and the anterior femoral condyle coming in contact. That's when the highest point of load occurs. Shows you where the mechanism is. This takes quite some time to return. Scott dies dead on bone scans. 18 to 24 months until they normalize. If you look at knee muscle strength and atrophy, what you see is deficits in movement control, deficits in strength that last out very often 2 years and beyond. So basically, when you look at all these factors together, about 2 years post-ACLR, even though we're sending these kids back between 6 and 12 months, they have sensory dysfunction, they have movement biomechanics dysfunction, bone scans that are hot, bone bruising that is still present. The graft is not yet matured. All the recent data, especially in hamstrings grafts, 18 to 24 months for that graft to ligamentize. And then you also have knee flexor and extensor atrophy and strength issues, and then psychological parameters. We've been doing this work with Kate Webster in very large 600 plus ACLR cohorts, and one of the best predictors of a second injury is fear, is avoidance strategies. And so what we're doing is using this return to sport risk model where we're looking at proprioception, muscular control, bone bruising, ligamentization, knee strength, psychological factors, and putting together an algorithm to predict risk, but also use it in rehab to lower relative risk. And basically we proposed this 5-factor model. We decided A good predictive variable has to have at least an R value of 0.4, which means it accounts for 20% of the variation in your model, so you don't need more than 5 factors. More than that is you're wasting time. So we're looking at proprioception, movement biomechanics, we're looking at demographic factors, maturation factors, strength, power, and then getting into psych factors as well. And I'm a bit of a Twitter troll. I grabbed this off of Twitter, and basically they cartooned our paper, which was kind of cool. But this gives the overall impression in a quick moment of what we're promoting with this work. So we've gone on and done these prospective biomechanical studies for second injury. This is my boy Eddie. As you can see, this is his second grade science fair, and he actually studied male pattern baldness. I have no idea why. But the good news is that it's a maternally inherited trait, and the kid's stress level has gone down significantly now that he's in his teens. So basically what we're doing is looking at these residual neuromotor deficits, and they're there. If you have any good, even rough method of looking at neuromotor control, it's gone, it's out, and it's bad for about 2 years. And this, again, Michael Owen tearing his graft, you can see some of these neuromotor control issues. And especially asymmetries are very important. And this is a lot of work from a whole team of ours, led by Mark Paterno, a student of mine. And basically what we show is that you get this after a knee dislocation like that, you lose that sensor. This is a good biomechanical study. He's dislocated his knee on the prior play. He's walking back with assistance, and just a slight movement of his center of mass increases that lever arm and collapses his joint. The problem is this data in young kids. Second risk is very high. If you're young, active, going back to the same level of sport, we showed that within 1 year, your risk is about a quarter of tearing your a second ACL, and within 2 years, it's about a third. Now, when we showed this data, I was a little bit worried. It was Mark's thesis, so we had to put it out there, but I was afraid people were going to say, well, you people in Ohio don't know how to reconstruct ACLs. But basically, then Kate and Julian and their group in Melbourne showed exactly the same numbers. And then Leo Pincheski showed exactly the same numbers again. And Aaron and Diane Dominant, the group at Mayo, showed exactly the same thing. If you're young, female, going back to the sport of soccer, 34% risk. So it's between a quarter and a third of a risk of a second ACL tear, very often on the contralateral side. So we use these same techniques we did in our prospective studies and basically showed that hip internal rotation, knee abduction leads to second ACL tears, and we can predict that based off the hip internal rotation impulse. Those who don't go on a second tear use their glutes and their hip complex to externally rotate their hips, whereas those that go on to a second injury have a net internal. They let the ground reaction force internally rotate their hip, adduct it, and abduct the knee. And basically, if you look at these 4 variables, net internal hip rotation moment, that 2D frontal plane abduction kinematic, side-to-side differences, and relative quad ham activation, and that stiffening strategy, we put that in a rock curve and basically could account for 94% of the variability with 92% sensitivity and 88% specificity. This is Baron Davis tearing his graft. What you see is that internal hip rotation impulse. So we have these varied return to sport rates. We have abnormal biomechanical strategies. We have this high secondary risk. And basically what we're currently doing with our current NIH grant is taking these current rehab guidelines, adding, after their release, more neuromotor control training to see if we can reduce the risk. We don't know yet whether we can do that. Lynn's data shows in males, it appears like you can. So 4 components of risk. What we're doing is addressing each one of these progressively, going after ligament dominance, quad dominance, leg dominance, trunk dominance, moving toward technique perfection, using phased, objective criteria rehab, because again, with that ACL sensory loss, we have to bring all our measurements, all are tools to bear to try to reduce the risk. And if you're not going to use objective criteria, I would suggest you better wait out 2 years, because you have to have that combination. And at Mayo, for example, Aaron and Mike and our team, they aren't returning people before 9 months, and if they've got another associated injury, a year. So you have to have the biology, but you also have to have the objective return. So finally, this is Carmen and Katie's genetic pedigree. At a fun family picnic, we collected blood on all the living relatives, and we've genotyped the entire family. And basically, this is Carmen and Katie down at the lower right, those two twin girl sibs. If you go up one generation to their dad, Tom, all the boys in that, they're triplets, and identical triplets, and all three have bilateral ACL reconstructions. So a very rich cohort to study. Finally, I'm not a clinician, but there is a quick case study here. So this guy has some of the signs of a high-risk playa. Well, this high-risk player makes a high-risk maneuver. Now, we could have screened and we could have intervened, maybe put on some stud blinders or some kind of psychological aversion therapy, but we didn't screen nor intervene. So he ends up perturbed and he's poshed. Now what happens, Beckham's really bent and it's too late. So don't wait, screen, intervene before it's too late. Finally, looking at neuromuscular imbalances in athletes, screen, look for that kid that uses her knees like ball and socket joints, intervene, and so hopefully you can prevent that injury from happening in the future. Finally, we do have a workshop every year. This year's the 16th and 17th of May. I want to acknowledge a lot of input from a whole lot of people over about 25 years. I thank you for your time this morning. I really appreciate it.